Hey folks, Ashley, allthingsdentistry.com. And in front of you, what we have is my take, or what I've been instructed on by a number of great mentors on soap notes. So I learned in dental school how to, and actually a few other oral surgery clinical courses we have I've been on, to use these soap notes. Instructor would say, okay, use your soap notes, collect your subjective, your objective, make your assessment, and go ahead with your plan. But I never really knew how to take the book theoretical ideological idea of soap notes and actually make it work for me, whether it be collecting the data, presenting it to the patient, or presenting it to a mentor, and or using it in my charts for recording the history. And I was taught by Dr. Chris Hart, a great mentor, and he really showed me how to use this format in the dental, oral surgery, endo, prosto world. So let's just take a look. I wanted to go over with that with you. So what we have in front of you is a soap notes subjective, objective assessment and plan, and how I use it fairly day to day. Subjective, you can go on anywhere. I mean, there's 1,000 of websites talking about the soap notes. This is more, like I said, specific towards dentistry because I'm a dentist. So when the patient presents, just capture the chief complaint, history of present illness, and any medical history. Now I suppose that medical history is in here because under subjective, until you can get a definite list of medications from a primary health care provider. So up until this point, it's subjective as to what they tell you. So in this case, this young man had asthma, used albuterol, no allergies, any past surgical history, involved ear laceration 2009, tobacco positive, and ethanol alcohol. He's positive for alcohol, social drinker. Now continuing on with objective, we take anything we can capture with our eyes or a machine. Vitals, objectively captured. Our clinical exam, we start from out to in, so fairly systematic. Take a look at the patient, step back, and ask them, where does it hurt? Point to the one place where it hurts. And they'll probably point to a number of things. And that will help in determining whether it's an odontogenic issue, whether it's a myofascial, or be it a temporomandibular joint issue. If they can pinpoint exactly where the pain is emanating from, that can really guide you. It's fairly helpful. Even taking a photo of it and recording that for future purposes is very helpful. So we start off extraoral, taking a look at and these are just notes so I remember, any asymmetry, any swelling, any redness, erythema, any pain, any paresthesia, and any joint issues. So I typically will write that there's no asymmetry, no swelling, and the patient pointed exactly where the pain was coming from. Again, on intraoral, same thing, sort of systematic walkthrough. Little memory words here, so I'm looking for those things, be it swelling, exudate or pus, erythema or redness, any hemorrhage, also known as bleeding, mobility, occlusion, pain, biotype, heart tissues. The last two are not typical of what you'd be looking for, but if it's going to be a comprehensive patient down the road, it may help just in your overall assessment. So in this case, I wrote down tooth number 16, etc., and tooth number 17. Continuing with objective, we've got radiological assessment. In dentistry, you typically have a periapical radiograph, a pano, and maybe a cone beam. If so, you could have other radiographs, Waters, Towns. Furthermore, I mentioned earlier that I use this also for endodontics. So this is a really good way to capture if a patient presents with endodontic pain or odontogenic pain and we're not going to be perhaps pursuing extraction, that I do my endodontic testing on here as well. But it also it reminds me, if I need to review my notes down the road, what the overall clinical exam was, instead of focusing down on one little tooth. And we take a look at the whole patient. So we've completed our data collection. Now let's assess it. This gives us an overall view of taking a look at the big picture, not just the one little tooth and how we're going to extract or remove the gingival tissue from that one tooth, but how does the patient's medical history affect? 9 times out of 10 it's not going to. But that 1 time out of 10, you sit back and think, well, in my assessment, like, maybe the medical history is contraindicates a surgical procedure at this point, be it hypertension, diabetes, etc. Smoker, so I'm just assessing the overall patient. And finally, our plan is sort of, what are we going to do today and what are we going to do in the future for this situation, or be it the whole patient. And in this case, I sort of put down a fictitious plan, but the key things are sort of the plan as to what's going to happen today, what's going to happen in a few days, what I'm going to provide for analgesia, and how am I going to follow up. And that's important not only for yourself to remember, say in 6 months when you come back and you're looking at the chart and the patient presents with paresthesia, etc., or somebody else picks up the case and is sort of wondering what happened. And then write down your treatment rendered today. So that's just an overview of the way I was taught in oral surgery rotation. And again, I use this for a number of the other disciplines just to capture my thoughts and write it out systematically, so when I go back I have an idea of what happened. I hope that helps. Cheers.